The title of the next presentation is Invasive and Non-Invasive Mechanical Ventilation, Basic Principles and Goals. My name is Paul Nuccio, and I'm the Director of Pulmonary Services at Boston's Brigham and Women's Hospital and also Dana-Farber Cancer Institute. I do not have any disclosures to report to you today. So let us begin today by looking at the difference between non-invasive ventilation, or NIV, versus continuous positive airway pressure, or CPAP. You can tell by the chart that the airway pressure levels are much different with the NIV group than they are with the CPAP group. For the NIV group, we have both an inspiratory pressure as well as an expiratory pressure, with the expiratory positive airway pressure being very similar to positive end expiratory pressure, or PEEP. Whereas with the CPAP mode, it's basically one constant level of pressure, allowing the patient to breathe spontaneously at that level. So with NIV, we have an IPAP and an EPAP, which results in changes in tidal volume and changes in pleural pressure. Some refer to this as BiPAP. We can also see with CPAP that although there is no ventilation assistance, there is an increase in lung volume and an increase in intrathoracic pressure. So what about the evidence to support the use of non-invasive ventilation? Well, this has been studied pretty extensively over the past 15 or 20 years. Pretty much every form of patient disease state has been looked at in terms of whether or not NIV might be beneficial. The reason for that is because of the complications that are associated with endotracheal intubation and invasive mechanical ventilation. So in terms of the evidence for non-invasive ventilation, there is very strong evidence for the use of NIV to support patients who have a COPD exacerbation, and also for those patients with cardiogenic pulmonary edema, or CHF. There is some pretty good evidence that suggests that non-invasive ventilation can also be used to prevent extubation or decannulation failure. There are a few studies that have looked at using non-invasive ventilation for the transplantation or immunocompromised patient, but it's really important that the therapy be instituted early. But for the most part, when we think about non-invasive ventilation and which patients tend to be the most successful, it is those with a COPD exacerbation or those with cardiogenic pulmonary edema. Here is a Cochrane database review from 2008 that included 14 different studies in the review, and you can see that the number to treat to show a lower risk of intubation and also a lower mortality rate when using non-invasive ventilation were quite low, again suggesting that the use of non-invasive ventilation is beneficial in patients with a COPD exacerbation. We see very similar results when supporting patients with non-invasive ventilation during episodes of cardiogenic pulmonary edema. Again, the number to treat is fairly small, both for decreasing intubation and for reducing mortality. There was really no difference found between those that used BiPAP and those who used CPAP. Very early on, there was some concern for patients using non-invasive ventilation as opposed to CPAP that they might actually be at risk for developing an acute myocardial infarction. However, more recent evidence suggests that there was no additional harm, such as an acute MI, from using non-invasive ventilation. Although one of the main treatments of acute hypoxemia respiratory failure in the past has been the use of CPAP, recent research has shown that high-flow oxygen therapy may actually be a good alternative. This is a study from 2015 in the New England Journal of Medicine that showed that although there didn't seem to be a benefit for avoiding intubation, there was a significant 90-day mortality benefit. And in this study, they looked at almost 5,000 patients initially who had acute respiratory failure, and of those, approximately 2,500 had acute hypoxemic respiratory failure, with 313 of them undergoing randomization. And when it was all said and done, each category was pretty evenly represented in the study. And again, it showed that for some of these patients, there may actually be a mortality benefit for using high-flow nasal cannula versus non-invasive ventilation. So when we talk about instituting mechanical ventilation, there are really three important components that we absolutely need to think about. One is patient selection. We want to be sure that we choose the right patient. It's not a one-size-fits-all situation. And not all patients do well with non-invasive ventilation. We also need to choose the proper equipment because that may determine whether or not the patient will even tolerate non-invasive ventilation. And unless that happens, we will not be successful with the therapy. And third, the skills of the clinician who will actually initiate the non-invasive ventilation are also equally important. In some ways, it's more difficult to initiate non-invasive ventilation to a patient than it is to initiate invasive mechanical ventilation. So the individual needs to have the appropriate skill set in order to do this effectively. So who are the good candidates for non-invasive ventilation? Well, we should be looking for patients who are sick but not too sick. The reason is if they are too sick, they may be beyond the point where non-invasive ventilation would be beneficial to them. They should also have a diagnosis of COPD or CHF or perhaps others, as the literature pointed out. There should be a need for some sort of short-term requirement for ventilatory support. And they may be someone who perhaps was accidentally or prematurely extubated and still need some additional support. So then, how do we go about selecting patients for non-invasive ventilation? So the first step is that the patient needs respiratory support. He or she requires some form of mechanical ventilation. So the patient is in distress, probably using his or her accessory muscles, has an acute respiratory acidosis, and a diagnosis such as an exacerbation of COPD or cardiogenic pulmonary edema. In other words, a diagnosis where we know that this therapy has been shown to improve outcomes. The second step is that there needs to be no exclusions to the provision of mechanical ventilation through a face mask rather than by an endotracheal tube. In other words, there needs to be no exclusions such as inability to protect the airway, a facial structure that makes it impossible for the intubation to fit the patient, a severity of illness that is too high, or simply a patient who is uncooperative or unwilling to try the therapy. We should also not attempt to institute this treatment if it happens to be against the individual patient's wishes. So again, we can see here some of the key exclusions: airway protection, unable to fit the face mask, uncooperative patient, and unstable hemodynamic status. I think it is also important to consider when the therapy is failing and when to stop, and consider other alternatives such as endotracheal intubation and mechanical ventilation. For example, if the patient is not improving within 1 to 2 hours after the initiation of non-invasive ventilation, it is probably time to consider alternative therapy. It's time to really consider endotracheal intubation. Or if the patient is intolerant of the therapy or has adverse effects such as hypotension, or if the patient's wishes are that he does not want a mask strapped onto his face. For these reasons, we should strongly consider stopping non-invasive ventilation and considering alternative therapy. Another thing that we need to consider is when to transfer a patient to an ICU if this happens to be done on a general floor setting area. I would suggest that anytime non-invasive ventilation is used in lieu of intubation, we should be moving that patient to an intensive care unit as soon as possible. Other concerns are listed, such as failure of non-invasive ventilation, or the patient cannot tolerate the interface. They require very high settings, and the patient's unable to tolerate the mask off even for short periods of time. We usually like to consider if the patient cannot do okay with the mask off for 15 or 20 minutes, then it's time to probably move the patient to an ICU. This type of patient can certainly be more closely monitored in an ICU setting as opposed to on a general floor setting. So over the past 20 or so years, there have been a number of different interfaces developed that can be used with non-invasive ventilation. If you look at the top row, it includes an oronasal mask that fits over both the nose and the mouth. There is a nasal mask that only fits over the nose, and then nasal pillows, something that some patients find less cumbersome to use. On the bottom row, we have a total face mask that covers the entire face. There's a hybrid setup that combines both a mask over the mouth with nasal pillows. And there's a helmet that is not yet readily available, or it's not available at all in the United States, although has been used very effectively in Europe and South America. So this fits over the entire head. The question that's often asked is, which interface would be best for my patient? Well, the literature would suggest that the use of the oral nasal mask is probably best for patients with acute respiratory failure. This is mainly because in these patients, mouth breathing and mask leaks can be quite problematic, and they tend to be better managed with the oral nasal mask. Ventilators used for non-invasive ventilation can either be devices that were designed specifically for that purpose, or we can use a critical care type of ventilator. The devices that are designed for non-invasive ventilation are typically pressure support ventilators that have good leak compensation. On these devices, we will set an inspiratory positive airway pressure, or IPAP, and an expiratory positive airway pressure, or EPAP. The difference between the IPAP and the EPAP is the pressure support setting. The EPAP, for all practical purposes, is the same as positive end expiratory pressure, or PEEP. This is different than with an ICU ventilator, where the level of pressure support is actually the amount of support that is applied above the level of PEEP. So the IPAP is the peak inspiratory pressure, and with pressure support, the peak inspiratory pressure would be the sum of the pressure support level plus the PEEP setting. When we talk about breath delivery from a mechanical ventilator, this is often described in terms of phase variables, and the phase variables of a ventilator consist of the trigger, which is what initiates inspiration, control, which is what the ventilator controls during the inspiratory phase, cycle, which is what initiates exhalation, and baseline, which in most cases would be the level of PEEP if it were dialed into the ventilator. The trigger may be initiated by time. In other words, we tell the ventilator to give 12 breaths per minute, and it will do so every 5 seconds. The breath can also be initiated by the patient by generating a change in either pressure or flow. In the control phase, the ventilator can either control flow or pressure. If it controls flow, it is also controlling volume at the same time. The cycle, or initiation of exhalation, can be done based on time, flow, volume, or pressure. And again, the baseline can either be set at 0 pressure or at a certain PEEP level. Every breath will begin and end at the same level that is the baseline. In this picture, you can see pressure-triggered breaths on the left and flow-triggered breaths on the right. You can see in the tracings on the left that inspiration begins when the pressure drops to a certain preset level. On the tracing on the right, the ventilator waits to see an elevation of flow for the initiation of the breath. So does it matter whether it is pressure-triggered or flow-triggered? Probably not, since modern ventilators today are extremely sensitive and require very little work for the patient to initiate a breath when set correctly. There are some issues that cause triggering difficulties, such as auto-PEEP, which is a buildup of pressure within a patient's respiratory system. This makes it very difficult for a patient to trigger the breath, but can usually be corrected by increasing the set PEEP level similar to that of the auto-PEEP level in order to counterbalance the problem. We can also see auto-triggering take place due to water in the circuit or circuit leaks, and occasionally cardiac oscillations may cause the ventilator to trigger due to the pressure oscillations within the system. So what are the different breath types available on a ventilator? Well, the breaths can be either mandatory or spontaneous, and with the mandatory breaths, they can be triggered or cycled by the ventilator with a backup rate. These breaths can be either volume controlled or pressure controlled. If the patient is breathing spontaneously, the ventilator can be triggered and cycled by the patient, and there is no backup rate. I should mention that even in a spontaneous mode, when there is not an actual set mandatory rate, there was always an apnea backup in the event that the patient stops breathing. So when I say no backup rate in spontaneous ventilation, I just mean that there's not a set mandatory rate to ventilate the patient. There is just a safety backup in case the patient stops breathing. Spontaneous ventilation breaths can either take place with continuous positive airway pressure or with a level of pressure support added. In volume-controlled ventilation, the ventilator will deliver a fixed flow rate, a fixed inspiratory time, and a fixed volume, while the level of pressure will vary with each breath based on the patient's lung mechanics and their effort. On certain ventilators, we can also choose between a square wave flow pattern or a descending or decelerating flow pattern, both pictured here. The square wave pictured on the left is also known as a constant flow waveform. An important thing to note that you may be able to appreciate from looking at these graphics is that if you change from one flow pattern to the other without making any other changes to what's set on the ventilator, the time it takes to deliver a breath can be quite different. In this picture, you can see that the inspiratory time is longer with the descending flow pattern. This is something that's very important to consider when changing from one flow method to another. This picture shows a pressure time scaler. PEEP would be considered your baseline, and the PIP, or peak inspiratory pressure, is the pressure that it takes to overcome the resistance to flow, not only in the patient's lungs, but also the resistance within the ventilator circuit and endotracheal tube. If we were to put in an inspiratory pause, this would stop the flow, which you can see at this plateau level, and it will in fact create an inspiratory pause and create what we call a plateau pressure. This plateau pressure is felt to be equivalent to end inspiratory alveolar pressure. So the plateau pressure is actually considered to be a much better indicator of what's going on within the lungs than the peak inspiratory pressure. The difference between the peak inspiratory pressure and the plateau pressure gives us an indication of the resistance to flow, or how much resistance there is in order to deliver a breath. In order to calculate the patient's lung compliance, we need to look at both the plateau pressure and also the tidal volume. In pressure-controlled ventilation, we deliver a fixed pressure and a fixed inspiratory time. The inspiratory flow rate is variable, meaning that flow and also volume varies based on the lung mechanics and the patient's effort. Many believe that having a flow rate that can be basically controlled by the patient may actually be beneficial in terms of patient comfort. although there is not any strong evidence out there that supports this comment. We can also provide pressure-controlled inverse ratio ventilation by increasing the set inspiratory time so that it is actually longer than the expiratory time. When ventilating this way, it would not be uncommon for the inspiratory time to be twice as long as the expiratory time. We would refer to this as an IE ratio of 2:1, with a normal IE ratio typically being 1:2. So it's just the opposite. Because more time is spent during the inspiratory phase of the breath, as can be seen by these tracings, the result is a higher mean airway pressure. This can sometimes result in an improvement in oxygenation. A potential drawback to doing this is that it could also result in autopeep or air trapping development because of a shorter expiratory time that may not give the lungs enough time to empty. It may also result in some hemodynamic compromise. Patients that are ventilated with an inverse ratio usually require increased sedation and possibly paralysis due to it being quite uncomfortable for the patient. We can also ventilate somebody in what's called pressure support ventilation. This is a spontaneous type of breath. It's patient-triggered and pressure-limited, and it's usually flow cycled. There is no set rate other than, again, if the patient happens to stop breathing, there is an apnea backup safety feature. So with most ventilators, we have the ability to adjust the way these pressure support breaths are delivered by adjusting either the rise time, which will change the peak flow rate, or we can also adjust the flow cycle time, which is when the inspiratory phase of the breath is actually turned off. Most ventilators usually default that feature to 25% of the peak flow. So once the breath decelerates down to 25% of the peak flow, the ventilator turns off and switches into the expiratory phase. But this can be adjusted. We may want to adjust this down to 10% in a patient that perhaps we want to try to capture a little additional tidal volume, or we may want to adjust it higher to, say, the 50% setting for patients with chronic obstructive pulmonary disease. And by doing this, this will shorten their inspiratory time and allow for more time for their lungs to empty. The basic ventilator modes that are available on most ventilators today consists of continuous mandatory ventilation, continuous spontaneous ventilation, and synchronized intermittent mandatory ventilation. Now, continuous mandatory ventilation, also referred to as CMV, is an assist control mode which provides a backup rate, so there's a set rate, but the patient can also initiate breaths on their own, which would be a full-size ventilator breath. This can either be done in volume-controlled ventilation, or VCV, or pressure-controlled ventilation, or PCV. In continuous spontaneous ventilation, there is no backup rate other than the apnea settings, which I mentioned previously. And we can deliver, these breaths can basically be entirely spontaneous with no baseline pressure, or we can add a PEEP level and provide continuous positive airway pressure, and we can also institute a certain level of pressure support ventilation to supplement the patient's breaths. We can also ventilate a patient in what's called synchronized intermittent mandatory ventilation, which can either be done with volume-controlled ventilation or pressure-controlled ventilation. And this is a mode that allows us to set a mandatory rate, but also allows in between those mandatory breaths for the patient to breathe spontaneously without any support. We can do this in either volume-controlled ventilation or pressure control, and we can or cannot add pressure support. That's up to the clinician's preference. So this mode of ventilation, referred to as SIMV, was once thought to be a very good method of weaning a patient from mechanical ventilation. The problem is it was a stepwise process, and it tended to lengthen out the time on ventilators as opposed to shortening it. This slide shows graphically what happens during synchronized intermittent mandatory ventilation, or SIMV. One of the things that I'd like to point out in this slide is the bottom tracing, which shows the esophageal pressure tracing. And what you see here is that regardless of which type of breath they receive, whether it's a mandatory breath or a spontaneous breath, the amount of work, which is indicated by the esophageal pressure movements, is actually pretty much the same regardless of what type of breath the patient is getting. So again, although this was once considered to be an effective way to ventilate and wean somebody off the ventilator, it's virtually never used anymore, and certainly not supported by any evidence. So let's talk about some goals to keep in mind when setting up a ventilator. We want to provide some limitation to the volume and pressure levels, as we know from the literature that we need to minimize or eliminate the potential for developing what's called ventilator-induced lung injury. We do want to apply an appropriate level of PEEP and try to avoid the development of auto-PEEP whenever possible. Another goal is to provide adequate gas exchange. Let me emphasize the word adequate and not normal. And I'll talk more about this later on in the presentation. We always want to strive to promote patient-ventilator synchrony, and we should also use the lowest possible FiO2 based on the patient's needs. In terms of volume and pressure limitation, we want to try to target a tidal volume of 4 to 8 mLs per kilogram. This is based on the very established evidence that everybody is aware of for ARDS patients. There is also some accumulating evidence that similar tidal volumes may also be beneficial actually in all ventilated patients, not just those with a diagnosis of ARDS. So the tidal volume used should always be based on the ideal body weight as opposed to the patient's actual body weight. For pressure limitation, we should always try to keep the plateau pressure under 30 centimeters of water pressure while considering the effect of the chest wall and the effect of spontaneous breathing. Most importantly, we want to keep alveolar stretch to a minimum. We want to minimize the amount of stress on the lung by maintaining a reasonable transpulmonary pressure. We also want to apply appropriate level of PEEP. We want to do that because we want to maintain alveolar recruitment, particularly in the ARDS patients. Most of the literature suggests that for ARDS patients who have a mild form of the syndrome, using a PEEP level of 8 to 12 centimeters of water would be appropriate. If they have moderate ARDS, probably more in line of 12 to 16 centimeters of water pressure. And for patients with severe ARDS, we want to usually set the PEEP level somewhere in the vicinity of 16 to 20 centimeters of water pressure. We can also apply PEEP, as I mentioned earlier, to try to counterbalance the negative effects of auto-PEEP. Auto-PEEP is caused by air trapping, which is also referred to as dynamic hyperinflation. We can often manipulate our minute ventilation by changing tidal volume and/or the respiratory rate in order to try to change the IE ratio. What we're basically trying to accomplish is to give the lungs more time to empty by lengthening the expiratory time, as I mentioned earlier. And the way we do this is by shortening inspiratory time. So auto-PEEP is also determined by the lung function, such as a patient's lung compliance and airway resistance. If we have an increased plateau pressure because of an increased work of breathing, we can have negative hemodynamic effects, could develop a pneumothorax, and also difficulty triggering a breath, as I discussed earlier. So again, we want to try to make corrections by reducing the minute ventilation and treating the underlying lung function so that we can try to get rid of the auto-PEEP. Another goal on our list is to provide adequate gas exchange. We do not need to strive for an oxygen saturation of 100% on every patient. It's probably more appropriate to target a saturation in the range of 88 to 92%, which will correspond to a partial pressure of oxygen in the arterial blood of 55 to 80 millimeters of mercury. We generally try to keep the pH level somewhere in the vicinity of 7.30 to 7.45 in most cases, although at times we prefer to ventilate patients following principles of permissive hypercapnia and permissive hypoxemia in order to avoid injurious ventilation. There are exceptions to using these techniques, such as patients with an elevated intracranial pressure or those with hemodynamic compromise. We also want to promote patient-ventilator synchrony. There are some things that can get in the way of that, such as some non-ventilator factors, including anxiety, pain, and acidosis, that will cause dyssynchrony of a patient with a ventilator. There's also some ventilator factors, such as inadequate ventilator settings. If the trigger is not set appropriately, it's going to be more difficult for the patient to initiate a breath, and that will result in patient ventilator dyssynchrony. If the flow is not appropriate for the patient or the cycle is not set correctly. Sometimes just a simple mode change will help a patient to become more in synchrony with their ventilator. As I mentioned before, we want to use the lowest possible FiO2 in order to meet the patient's needs. This is important because we want to try to reduce the possibility of problems related to oxygen toxicity. If we have somebody that we're concerned about oxygen toxicity, but they're also being over-distended by the ventilator, the over-distension would trump the oxygen toxicity, and even though we might need to be on a high amount of oxygen or a high FiO2, we need to do whatever we can to avoid lung over-distension. So in terms of FiO2, again, try to maintain that between 88 and 92% in terms of pulse oximetry, and that tends to be usually sufficient. Try to avoid what I would refer to as the seduction of the pulse oximeter. That seems to be one monitor in ICU rooms that people look at all the time, and because they can see it all the time, many people want to do something to try to get that number up closer to 100%, and I would suggest that's probably not only not necessary, it could actually be harmful to the patient. So again, when setting a ventilator for a patient, we need to keep these four major components in mind. We want to provide adequate gas exchange. We want to be aware of the patient's hemodynamic situation. We certainly want the patient to be as comfortable as possible, and we want to do, again, whatever we can to avoid ventilator-induced lung injury. So the basic components of mechanical ventilation fall into these four different categories: pressure, volume, flow, and time. If we can understand these four different parameters, then we should have a pretty good basic understanding of what mechanical ventilation is all about and how mechanical ventilators function. So let's now take a look at a few questions which I have here listed on the slide. Which of the following is most important related to ventilator-induced lung injury? The choices I have listed here are A, volume and pressure limitation, B, keeping the FiO2 less than 60%, C, patient ventilator synchrony, and D, maintaining normal blood gases. So which of the following is most important related to ventilator-induced lung injury? The correct answer to this question would be answer A, volume and pressure limitation. The reason for that is because that is the most important thing we need to consider in order to avoid ventilator-induced lung injury. If the volume is too high or the pressure is allowed to go too high, this could in fact lead to ventilator-induced lung injury. The next question, which of the following has strong evidence supporting the use of non-invasive ventilation? The choices are A, COPD exacerbation, B, acute congestive heart failure or cardiogenic pulmonary edema, C, ARDS, or D, both A and B. So again, which of the following has strong evidence supporting the use of non-invasive ventilation? The answer is D, both A and B, both an acute exacerbation of COPD and acute congestive heart failure or cardiogenic pulmonary edema. And the third question, which of the following affects peak inspiratory pressure with volume-controlled ventilation? The choices are A, the respiratory system compliance, B, the tidal volume, C, airways resistance, and D, all of the above. So again, repeating the question, which of the following affects peak inspiratory pressure with volume-controlled ventilation? The correct answer is D, all of the above. The compliance affects peak inspiratory pressure, the tidal volume will, and whatever the level of airway resistance is will impact the peak inspiratory pressure as well when ventilating in volume-controlled ventilation.